now we would like to come to the burden of liver cancer in Europe. And it's my pleasure to introduce Professor Peter Galle, who is a liver cancer expert from the University Medical Center from Mainz, Germany. Please, Peter.
Thank you for the opportunity to share some data on the burden of liver cancer in Europe. These are my potential conflicts of interest with respect to hepatocellular carcinoma. This is the structure of my presentation, and I will start with epidemiology of liver cancer. Worldwide, it's actually a very common cancer, and in most years ranks at number 2 as leading cause of cancer death worldwide. In the Western world, in developed countries, it's less common, is rather a rare disease, but nevertheless occurs. These are data for Germany, and you see the cancer registry data and the dominance of male patients. What we observe with some concern is that there is an increase in numbers here for men and women with respect to primary cancer of the liver over the years, estimated data here. And the reason for the increase, as it's also observed, for example, here in UK, is that we see certain rise of non-alcoholic fatty liver disease as an etiology, which is in some parts of the world already a dominating etiology. We have two types of primary liver cancer, those developing from hepatocytes, more common, 80 to 90%, and those developing from cholangiocytes, bile-producing and transporting cells, 10 to 20%, and then rare tumors which are not to be discussed today. There are defined risk factors for the development of hepatocellular carcinoma and also cholangiocellular carcinoma, and that is alcoholic cirrhosis, viral hepatitis, non-alcoholic fatty liver disease, as I said, with an increasing incidence, and other contributors. The etiologies are treatable, and the risk factors are known. In that setting, it's actually disappointing that if we go through these stages, that the majority of our patients today in Europe are diagnosed at a stage where curative intent interventions are no longer possible, as for example would be transplantation or resection. So most of our patients are not able to receive these curative intent treatment options. Nevertheless, there's also some light at the end of the tunnel in terms of systemic therapy. We have seen tremendous progress in the treatment for liver cancer, and as an example, the most recently developed now new standard of care is immunotherapy with atezolizumab and bevacizumab, resulting in a median overall survival in rather advanced stages, almost 20 months, which is significantly longer than what we used to have in the past. There is also an economic burden of liver cancer. It's not as high as with respect to colon cancer, but with 4 billion euro per year, it's quite significant, ranging between esophagus and stomach cancer. In summary, Mr. Chairman, ladies and gentlemen, liver cancer worldwide is a very common and very deadly tumor, and it is on the rise in the West. Hepatocellular carcinoma is the predominant pathological type of HCC, followed by cholangiocellular carcinoma. We have seen this rise over the years in most European countries, and projections go that this will continue in the future. We have defined risk factors, viral hepatitis, alcohol, non-alcoholic fatty liver disease. Patients with advanced liver cancer have a poor prognosis, but the prognosis is at least improving due to new systemic interventions. There's a significant economic burden to the healthcare system from hepatocellular carcinoma. Liver awareness, HCC awareness, would be important to get this tumor diagnosed at an earlier stage. Thank you for your attention.
Thank you very much, Professor Galle, for setting the stage on liver cancer burden in Europe. Now it gives me my pleasure to introduce Professor Peter Jepsen. He's an EASL Policy and Public Health Committee member and an hepatoepidemiologist at Aarhus University Hospital in Denmark, and who will give this talk on the importance of prevention of liver cancer with vaccination and treatment. Please, Peter.
Yes, hello everybody, and thank you very much for the opportunity to give this talk on the prevention of liver cancer with vaccination and treatment. I have no conflicts of interest. We know that between 80 and 90% of our patients with liver cancer have an underlying chronic liver disease, liver cirrhosis. And liver cirrhosis in itself has a very poor prognosis, even without liver cancer. So we can see liver cirrhosis as a stepping stone on the path from a healthy liver to liver cancer. So we can really kill two birds with one stone by targeting the risk factors for liver cirrhosis and for liver cancer. And they are viral hepatitis types B and C, alcohol, and obesity. What you see here is a map of Europe, and it shows the incidence of liver cancer in 2020. And you can see that the incidence is higher in the southern part of Europe than in the northern part. And these geographic differences really reflect differences in the prevalence of viral hepatitis. Viral hepatitis type B spreads from mother to child at birth, and it spreads between children. In adolescents and older people, it spreads as a sexually transmitted disease, and it also spreads through intravenous drug use. When we talk about prevention of hepatitis B, vaccination is really the key thing. We must vaccinate all children against hepatitis type B. For those who are already infected with hepatitis B, we have treatment, but that treatment is often long-term, sometimes lifelong. And the aim of this treatment is to prevent development of liver cirrhosis and liver cancer. It also reduces the risk of transmitting the infection to other people. Viral hepatitis type C can also spread from mother to child at birth, but in Europe, spread through intravenous drug use is really the main culprit. And because the virus was only discovered in 1989, many people were infected through blood transfusions received before that time. When we talk about prevention of hepatitis type C, treatment is key because there is no vaccine available. But over the past decade, we've seen a revolution in treatment. So our modern treatment is really curative, and essentially all people can be cured with a short, often 12-week treatment course. That is why we have the treatment as prevention paradigm. By treating hepatitis C, we can prevent liver cancer. When we talk about alcohol and obesity, we know that hazardous alcohol use and obesity cause liver cirrhosis and liver cancer. And of course, they cause other diseases and injuries too. So we can reduce the incidence of liver cirrhosis and of liver cancer by tackling these risk factors. But in fact, the prevalence of obesity is going up. And in many countries, the prevalence of hazardous alcohol consumption is going up too. Of course, we have no vaccination against alcohol or obesity, and also we have no really effective treatment. So what we need here is policy interventions, taxation, reduced access, minimum pricing, restrictions on marketing, and information and support. So these two graphs illustrate how deaths from liver disease fell dramatically during the two world wars in countries that imposed restrictions on alcohol sales, France and England and Wales. And we saw no such reduction in deaths from liver disease in the United States and Canada. And to the right, you can see a close-up of the time trends in England and Wales, where you can also see the alcohol consumption during the same years. And what we can see is that deaths from liver disease and alcohol consumption really run in very close parallel. And that's really the type of evidence we have that these interventions work. We have what economists like to call natural experiments, where different countries introduce different policies at different times. Now we can see that the incidence of liver cancer has gone down in countries that implemented hepatitis B preventive measures first. We can also see that the incidence of liver cancer correlates with the prevalence of obesity over time and over place. We know that in individual patients, the risk of liver cancer goes down after successful treatment of hepatitis C infection. So in summary, we focus on viral hepatitis types B and C, on alcohol and obesity because they cause liver cancer and liver cirrhosis. For hepatitis B, vaccination is key. Treatment is also available. For hepatitis type C, treatment is the key. For alcohol and obesity, we need policy interventions. Thank you.
Yes, thank you so much, Professor Jepsen. Thank you, Peter, for these clear words. And I think quite in line what we have said is that we will now get an example from Slovenia on viral hepatitis elimination. And this will be presented by Professor Moka Maticic. Professor Maticic is an EASL Policy and Public Health Committee member, an infectious diseases and internal medicine specialist from the University Medical Center in Ljubljana, Slovenia. So please, Moika.
Thank you, Thomas, and good morning, ladies and gentlemen. It's really a great honor and privilege to be here with you today. So as we've just heard, treatment works as prevention of liver cancer, particularly for hepatitis C, which is a curable disease. And with the advent of new, highly effective and safe drugs, in 2016, the WHO set up the first global health sector strategy to eliminate viral hepatitis as a public health threat and to decrease HCV-related mortality due to cirrhosis and liver cancer by 65% by the year 2030. But in reality, in Europe, only a quarter of HCV-infected have so far been diagnosed, and only a third of them have so far been treated. The problem is that the natural course of HCV infection usually progresses silently for decades, and the infected are usually unaware of it. Besides, HCV infection most commonly affects the marginalized, the vulnerable, and the underserved populations, raising inequity in its management. So it's of utmost importance to scale up HCV testing and treatment and to find and cure the infected as early as possible. Well, in a 2 million population of Slovenia, the HCV prevalence study was unfortunately not performed. However, in the early 90s, several studies revealed the prevalence, high prevalence in some high-risk populations. And in 2015, it was shown that 2/3 of infected reported drug use as the mode of infection. The management of HCV in Slovenia has been recognized by the WHO as a good practice example. It all started way back in 1997 when the National Strategy for Management of Hep C was established nearly 25 years ago, just by integrating the continuum of services such as HCV testing and treatment into routine healthcare activities. And since then, hepatitis C has been treated in 5 centers around the country, mostly by infectologists. It's been available and accessible to everyone and covered by the National Health Insurance System with no restrictions. In 2007, special focus was directed to people who inject drugs by integrating 5 viral treatment centers and 18 centers for treatment of drug addiction. And this system very quickly yielded some amazing results in treatment rates. At the advent of new drugs, model projections showed that WHO elimination goals are feasible by 2030 by slowly increasing the testing and treatment rates. But to speed up this process, accelerating testing and treatment rates was needed through active case finding. So an algorithm for testing based on risk factors, extrahepatic manifestations, unusual signs and symptoms, and so on, was introduced into a routine clinical practice. And testing in Slovenia can be performed either within healthcare system or within the community. And the most recent reports show practically no positive HCV results within testing of the general population. But for the population at high risk for HCV infection, active case finding was precisely performed for those who are under regular medical supervision, as well as for special populations such as people who inject drugs and prisoners. So by 2018, a so-called micro-elimination was completed in several high-risk populations. It means that there are no more Hep C cases among patients with hemophilia, among patients on hemodialysis, among organ transplant recipients, and among HIV co-infected. As for people who inject drugs, the interventions were adapted to their specific needs. So in those managed at various programs, the treatment rates, as you can see here, and treatment results turned out to be very well. However, in others, mobile outreach units will be introduced next year for testing and linkage to care. Taken together, all those data presented and guesstimating the baseline national HCV prevalence at 0.23%, in Slovenia, so far, estimated 86% of infected have been diagnosed, and estimated 62% of infected have so far been cured. But the burden of HCV-related liver cancer in Slovenia has so far not been evaluated. However, a closer look to a very well-studied cohort of hemophiliacs that were all infected before 1993 and have eliminated hepatitis C has shown that among 73% of infected, 3 of them developed liver cancer, but 1 of them refused treatment of Hep C, 1 was late presenter, and 1 was unsuccessfully treated with interferon. So taken together, the knowledge on liver cancer and national data on HCV, the management of hepatitis C, particularly accelerating and treatment in accordance with the national clinical practice guidelines, has been included in the 3rd national cancer plan that has just been prepared. So to conclude, ladies and gentlemen, hepatitis C is a curable disease. Treatment works as prevention of liver cancer, but it's very important to develop a comprehensive Hep C national strategy and or action plan to eliminate hepatitis C, to build integrated HCV test and treat models of care, to make them simple and patient-oriented. It's important to fight stigma and discrimination, and last but not least, to include testing and treatment for HCV into the National Program for Cancer Management. Thank you very much for your attention.